Michael, what would you add to this list? We said getting my cognoscopy, nutrition, exercise, sleep, lowering stress, brain training, detox, glutathione levels, targeted supplements like omega-3. What else is on your focus list, or should we just add to do the still point and the cranial pumping?
Yeah, which is what I was going to say. Obviously, cranial sacral therapy, because part of the reason why is that what we found is that it not only affects the brain when we do cranial sacral therapy, but the body. And because you're getting more flow and more opening up of the connective tissue structure, muscular structure, lymphatic structure, and all the basic body structures, then what it means is that you're getting better metabolic uptake for everything that you're changing. So with nutrition. So when I talk about the body energy longevity prescription, similar to what Dale said, it's what we're doing is we're looking at exercise, we're looking at diet, looking at cranial sacral therapy, and then supplements. And, you know, as he pointed out, different people have a different physiology. Some people can get away with a lot, and other people not so much. Some people have a genetic factor, right? So you need to bracket that. Some people have had more insults to the body. They've had more close-hit injuries. They've had that. So those are all factors that when you want to sort it out, you need to look at the specifics as well. But in general, that's what we're saying. But again, it's really the idea you want to look at the whole spectrum of where somebody is and start to target in, which is what we do clinically with our work too. We're kind of like listening to the body, complementary to doing any of these other analyses that we're doing. We're listening to the body and feeling like, well, here are restriction patterns. What's the history? Has there been an immune system insult, which we deal with as well? Has there been other factors? What's happening in the gut? You know, that's kind of like what we're after and what we're doing. So I'm just adding to that. It's just a little bit of a different angle of really the same approach. And sleep, for example, if I could say, is just really an important piece just in that. I think it was University of Boston, or Boston University a couple of years ago. They did a scan they provided, and they showed that there's a flow of blood, and then during sleep, it invites a wave of cerebral spinal fluid to be invited in. It's as if about 60% of the clearance of toxins from the brain occur during sleep in the lymphatic system. And cranial sacral therapy helps to kind of help set up that sleep, make it more profound, and even make that exchange deeper. So it's very interesting that it's a way to complement sleep as well, which is very important, as Dale said, to kind of include in that cleansing process.
The speaker before you, Steve Hendricks, went beyond the Keto Flex 12-3. He said, ideally, narrow your eating window to 8 hours, and in a perfect world to 6 hours. Do you believe that would be beneficial?
In some people, that can be harmful, and in some people can be beneficial. So here's the trick. So we recommend 12 to 16 hours of fasting at night. So I think we agree on pretty much on the time window. The issue here is that some of the people who have cognitive decline, as you know, can be frail. And so the people who are at BMIs of 22 or more, I have no problem with that. But we have people that will come in with a BMI of 18. So they'll be underweight. And then you try to now stack a long fast on them, they actually get worse. And we've seen this happen. So you want to kind of judge depending on whether you've got fat to burn. You have to remember that what happens is your brain can only burn one of two things. And when we see, Alzheimer's disease or the beginning of Alzheimer's, this is a network insufficiency. We're not supporting. There's too much inflammation, too little energetics. So we're not supporting this extensive network of 500 trillion synapses enough. And it is protecting itself and it is downsizing. So normally you are metabolizing glucose or you're metabolizing ketones, and you should be able to go back and forth. That's called metabolic flexibility. However, as we get a little older, many people lose both of those. They can no longer metabolize the glucose the way they could before because they have insulin resistance. And by the way, that is the signature of Alzheimer's on a PET scan. Reduced glucose utilization in the brain in the temporal and parietal regions, as well as the precuneus and the posterior cingulate. But these are the main areas here that are reduced. So you have to be very careful. You've now got ketones that'll back that up. You've lost the glucose. Well, the problem is you're not making the ketones, again, because of the insulin resistance. Your high insulin levels prevent you from making those ketones. So when we see people with cognitive decline, that is an energetic emergency. We need to restore their insulin sensitivity, which is, by the way, why the fasting, that's helpful for that, but it's why you have to be careful if you start with fasting or you do too much fasting. And then we have to restore the ability to make and use ketones. So this is why at the beginning, we tend to give people exogenous ketones just to give them some form of energy. And then over time, we can get them into ketogenesis. So you just have to be careful if you have these long fasts. As long as someone's got fat to burn and they are able to make ketones, hallelujah. But for many people, they're not.
Okay, I'm going to come back to diet, but as far as brain training, what exactly are you all recommending for stimulation? Should we read? Should we do puzzles? Should we play, do dance and ping pong? Should we avoid TV? Is this fluffy science or is this serious science? What is the reality about mental stimulation and where we get it from?
That's a good point because, in fact, both of these things are really helpful. So there's no question, no matter how skeptical you are, that people who have included some form of brain stimulation, now, that's not to say you forget the biochemistry. You know, you're improving your methylation, you're improving your inflammation, all these things. But then having some form of stimulation is helpful. They get the best outcomes when you include that. Now, there are two general types. You mentioned both. So one of them here is going to be things like brain training. And yes, you're ping pong, great. Learning to do some dances, great. Any of these things, anything that's a stimulation, you don't want to have a lot of stress because stress by itself is a problem. So enjoy it, find something you love, Sudoku, Brain HQ, whatever it is that you like. Separately, you can find some stimulation through photobiomodulation. That's a big one. Some people like to use magnetic resonance stimulation, transcranial, any of these things, mild stimulation. And there are a number of good photobiomodulation groups out there that will actually give you some stimulation. And this does seem to give better outcomes. So those two things together can be very helpful.
Michael, what kind of results have you seen with your people who have taken the cranial sacral seriously and followed up and kept doing it? Is this something that you've consistently seen good results, and how powerful is it? In other words, for people, they've got to decide how to spend their time. And if people say, I'm going to take this 2-day training, how good have the results been and how often does it happen?
Well, let me go back a little bit to where our beginning was, okay? Back in, I think we've been at this now 15 or 20 years. In our initial study in a nursing home, we published the results in 2008 in the American Journal of Gerontological Nursing. And just as a bit of a background, and we looked for 6 weeks by doing this cranial sacral still point once a day for 15 or 20 minutes. And after about 3 weeks into the 6-week study, we began to actually see some change. We began to actually see that people started to recognize their caregivers. One of the biggest results we found is that we saw a decrease in agitation. And we used something called the Cohen-Mansfield agitation study, which actually shows that we're lowering sympathetic tone. We just mentioned about stress. Well, if you can lower the stress level in any way, shape, or form, that's pretty significant. And that's part of what the cranial seems to show that it does. So we did that. And then we saw that even we started to see changes in activities of daily living, that people were starting to be able to take care of themselves. Now, that was an initial baseline. That's very, very minimal. But even with that, over the 6-week period, we saw clinical and statistical significance that was continuing. And then anecdotally, for the last decade or so, we've tested this on hundreds of people and had people go through this protocol. And basically what they found is that they, at the very least, don't get any worse. They may not get better, but they don't get any worse. And we've seen that in a lot of cases, people don't end up in nursing homes because it kind of like stopped them at that area. So that's one thing. And then what we started to do is create advanced techniques and intensive programs that we have so we can get in and look at prior insults to the body that may have been, decades in the moving. We found that it's not like one day somebody wakes up with Alzheimer's like you have the flu or something. Something has been brewing in the body, often metabolically, and very often it's an inflammatory response, what I call a lot of the diseases of aging that have been going on for decades, maybe before they get an official diagnosis. So our idea in terms of prevention is that if we can come in and stop that before it gets to the point where it's at what I would call it early, even to the mid stage, which often is a lot worse than people think it is by the time we see them, that we can actually change the trajectory of the disease process. So it's a measure of frequency and intensity. The more we can do it, the more consistently we can see the result. But in a large variety of cases, we've seen, people get result. And what's required, though, is that there's consistency of treatment to get the best results.
Can we get that video ready that we made from the other day? I want to show that when it's ready.
Yeah, I'll take care of that. Yeah.
Okay. Is Alzheimer's type 3 diabetes, is that an accurate term or is that not accurate?
I would say, functional medicine talks, Mark Hyman's been talking about that for years, that when you talk, at least in a certain variety of cases, it's inflammatory and you have problems in the body. That simply put, there's inflammation in the body, and then eventually that overflows into the brain. So that's a popular way to put it. And there's a lot of tracking. If you just go into a nursing home and do a random survey and ask how many people that have been diagnosed have diabetes, a large percent of them will say, they've had that, not surprisingly. So go ahead. Yes.
Yeah, I mean, there's no question that it is a common risk factor, and it's been well described that diabetes is about doubles your risk for Alzheimer's, and metabolic syndrome increases it even more. But it's not the whole story. So as I mentioned earlier, I mean, this is really about inflammation. It's about activation of your innate immune system. It's especially the innate immune system's memory, which lives at 3 different sites, which lives in the endothelial cells, in the bone marrow, and then in the tissue macrophages, which in the brain are the microglia. And these are, no question, affected in Alzheimer's disease. It's essentially instead of type 3 diabetes, I would call it a chronic innate encephalitis. There is inflammation, it's chronic, and it affects your brain for decades. So that's part of the story, type 3 diabetes, but by no means is it the whole story.